Good morning, everyone. Thanks for having me with you today. As Deborah reminded me, I know I'm standing between you and lunch, but hopefully we can have a good interactive discussion today. So I'm here to kind of check in with you all on the progress that we all are collectively making with implementation of the Affordable Care Act. We certainly at CMS are completely committed to partnering with states to make sure that they have the resources they need, the support they need, and the information they need to make the decisions that all need to take place between now and October 1st, which is the date we refer to as the official kickoff of the Affordable Care Act implementation. October 1st is the date that the doors will open for the federal facilitated exchange and the state-based exchanges. That open enrollment period begins October 1st. So that is our goal date, and that is, I'm reminded constantly, only 101 days from today, counting weekends. So we're working a lot of hours, and I know the folks in the States are as well. So I'll just start it off with a couple of kind of key principles here in the way that we're approaching the new Medicaid program, as we like to call it, kind of a new day at CMS. We're focusing on, in addition to the specific implementation of the changes brought about by the Affordable Care Act, really trying to also make some larger systemic changes to how the Medicaid program works and to make some of the improvements and fixes, if you will, for the things that haven't always worked so successfully with Medicaid. We're working with states on looking at reforming their delivery systems, how care is paid for and how outcomes are measured and quality is measured, and putting some financial incentives in place for states to work with the provider community to achieve some of those goals. We're working constantly on improving the process for states and for providers. We are trying to streamline our review and oversight of things at CMS to make sure that states, again, have the resources they need, that it doesn't take 2 years to get approval for a request for something, and also to really focus our energies on the things that are truly important and not waste time on things that are, can be perceived as just us sticking our noses in where they're not welcome. So we are trying to do the best we can to preserve state flexibility, but also have, some standardization in our policy across the board. And then perhaps our biggest focus in the Medicaid program from those of us at CMS is to really make sure that the consumers that are participating in the program have a high quality healthcare experience, that the health coverage that they receive through the Medicaid program is high quality, accessible to them, and that it develops some outcomes for them that they should be able to come to expect, not much different than what's available in the commercial market. So this is the way we've approached the implementation of the changes to Medicaid from the Affordable Care Act in particular, which is to keep it simple as much as possible. This is actually the first application for the Medicare program, and Harry Truman got to be the first Medicare beneficiary back in 1965. And we like to look at this as a model because it's pretty straightforward, right? Do you want Medicare or not? We don't ask a lot of other questions about where the person lives, if they're pregnant, if they have been married before, what their immigration status is. We just need to know that Harry Truman wanted Medicare and he lived in Missouri. So similarly, we are trying to work toward, as I mentioned, the kind of positive consumer experience. So we're looking toward having a really integrated enrollment process that will start on October 1st. The law requires that every individual have the opportunity to apply for coverage on a single streamlined application, which I'll show you a picture of a little bit later, but that they can apply use the application in any state across the country. They can come in any door that works for them, whether it be online through the federally facilitated exchange portal if a state is not running its own exchange, online through the Medicaid agency, by phone, by mail, certainly happens a lot today, and then of course in person. The old traditional need for consumer assistance is not going to change in the world of 2014, and so that in-person assistance is going to continue to be very important. And so they fill out that application, they will provide the information, we will look at their income based on the new way of considering income, which involves looking at tax rules, and we talk about that as modified adjusted gross income. That will be, those considerations will be used for the exchange as well as Medicaid and CHIP. So you're providing one set of information, and on the other end you get an answer about which program you're eligible for. So you can then move to enrolling in the marketplace coverage, the qualified health plan coverage, or in the Medicaid or CHIP program. So again, it's really meant to be 4 simple steps where folks come out at the other end with an insurance card that's most appropriate for them. So this is just showing a picture nationally of who the population is that we're trying to serve. And as you can see, the vast majority of individuals who are uninsured today, for a variety of reasons, are in that lower income band of 0% of poverty to 400% of poverty, which is the range of coverage that's provided by the new law. So we're very much hitting at the target population. Of course, there's an expectation that not everyone will get coverage in 2014, but we are really having an opportunity here to make some significant changes. This is a picture of the current state of play in the Medicaid program and CHIP programs today in terms of who's eligible for coverage. So as you can see to the left, the children's population up to 250% of poverty is, states have done great work in advancing coverage for children, and so you have much higher eligibility levels there. Pregnant women have been another population that states have really committed to and ensuring that they get access to that important prenatal care and postpartum care. Working parents and jobless parents, there's some interesting distinctions there between those two populations, but as you can see, we're now down to very low income levels for coverage of parents in most states. Childless adults, of course, the population that's most targeted by the new Medicaid expansion and the Affordable Care Act, the average today is that states do not cover childless adult populations. There are some exceptions, but most states do not even cover them at all right now. And then the population of the elderly and individuals with disabilities are, hovering around 80% of the federal poverty level. But again, the program is focused on low-income populations. And so this is the new picture of what's possible in 2014. As you can see here, we are trying to set up a seamless system of coverage where there are options for just about anyone who comes in the door. And that there's a continuous flow of coverage, and so we certainly expect that people might start out in the exchange, have a change in their income, but would be able to move to Medicaid and vice versa. So we're expecting a fair amount of moving back and forth between programs, but are very committed in trying to set up the underlying systems to assure that those transitions are seamless for people and families. And so this is the picture of how it would look if a state does not expand coverage. And so you see there's a little bit of a white hole there at the bottom where the effect will be that the lowest income populations will not have a coverage option, even though others with higher incomes will have some highly subsidized coverage options. So I think everyone hopefully is pretty well informed about the Medicaid expansion opportunity, which is that the federal government will provide 100% funding for 3 years for the extension of Medicaid coverage to low-income adults with incomes up to 133% of the federal poverty level. That equates to about $15,000 a year for an individual. So again, we are talking about the lowest income population in the country. States absolutely have flexibility at this point to decide when to expand, and do have the flexibility to later drop the coverage, and there's no federal penalty associated with that. So if a state decides that they want to wait a year or 2 years to expand coverage, there's no federal parameters around that. I'll show you in a minute, but it should be noted that the 100% federal funding only lasts until 2017, at which point the coverage scales back to 95%, 94, 93, but then flattening out at really a 90% federal matching rate there, which is significantly higher than what's available today. Today, the average federal matching funds is about 57% in any given state. So even though the Supreme Court decision did change that expectation about the Medicaid expansion, the rest of the provisions of the Affordable Care Act remain in place, and I'll talk a little bit about some of those in a minute. But one of the important things to note is that through regulation, actually, we were able to provide states 90% federal funding for enhancements and building new, actually, eligibility enrollment systems. So this is an opportunity where states have had, in many cases, legacy systems that date back to the 1970s, where they're running their eligibility rules through those systems. And so now we've been able to give states this opportunity in alignment with making the changes for the new law to really replace their systems at great federal support. So just concluding, I think I've made this clear, but there is definitely no deadline for states to make the decision about the expansion of Medicaid. And I think on your last panel, someone mentioned, sometimes in the beginning of the Medicaid program, it took a few years for states to come on board. So we're expecting that will be an evolution over the next few years. So these are some of the key principles of the larger law, those provisions that are in effect whether or not a state elects to expand. So I've already mentioned the single streamline application for all programs. The modified adjusted gross income counting rules. Again, there's some standardization across programs with using those rules. And overall, they are much more simplified than what's in place today in Medicaid. We talk a lot at our agency about the data-driven eligibility and renewal systems, and it's very important that, that these systems get into place so that people will have that positive consumer experience when they try to enroll in coverage, and that there's connections made between the exchanges and Medicaid and CHIP. The other thing we've done is try to simplify the coverage rules for the different eligibility groups. Today, before the new regulations take effect, we have six eligibility groups for pregnant women. I couldn't tell you what the distinction is between those groups, but we have now collapsed them together. So there's one eligibility group for pregnant women, one eligibility group for children in the Medicaid program. The other thing I think I've kind of laid the foundation for here, but is that we're really working to make sure that there's coordination with the exchange to ensure that people stay enrolled in the appropriate program and again have seamless transitions when their circumstances change. So I've mentioned this a couple of times already, but the low-income adult coverage is 100% federally funded. Oh wait, this is the same slide, sorry. I'm going the wrong direction. There we go. So this, sorry about that. This is showing the funding picture. So again, obviously the purpose here is to show the level of federal support for the expansion and that the addition of state funds really doesn't even start until 2017 for this new population. And so, the population that we're talking about that's potentially going to be in this expansion group are people that you would think might have coverage already, but parents of children that states now cover through Medicaid or CHIP. Parents of children who have grown and left home. We talk about them as childless adults, but in many cases they have children, but their children are grown or they are not caring for those children anymore and are considered childless adults. So there are, somebody who is 62 years old and not eligible for Medicare yet could be considered a childless adult in the new context of the expansion. Many states, as I noted on my earlier slide, cover women when they're pregnant, but don't cover them when they're not pregnant. And so, again, the new expansion group would give an opportunity for those women to have coverage when they're not pregnant. I mentioned older people still too young for Medicare. My dad was a perfect example of this. He was uninsured after he retired from his small business and could not get individual coverage that was affordable to him. So he would be a population that would have the opportunity for coverage today before he was eligible for Medicare. Younger people starting out on their own. We hear a lot in the press, right, about the young invincibles. These are the young people who are potentially going to be eligible for this program, and certainly for exchange coverage as well. But those restaurant employees or part-time workers out there who are 22 years old might need some coverage if they're not on their parents' plan. And then individuals who have healthcare needs but are not quite in enough poor health to have a full disability determination are people that could potentially be eligible under this new group. So those folks who need some extra care but have not had the disability determination that would prevent them from this group could enroll in Medicaid through this new population. And again, all of these populations are potentially going to qualify for that 100% federal matching funds. So the other thing I wanted to point out about the work we've been doing over the past couple of years to implement this new law is that, we really did not recreate the wheel here. I should say we are kind of recreating the wheel. We're building on the state successes that have been in place in many states for 15 or 20 years. The CHIP program provided a really instructive example for how to do a great job with getting people enrolled, keeping them enrolled, and how to make that consumer experience a positive one for families. So, the streamlined application is certainly one. People talked a lot back in the days of CHIP of states taking their 30-page cumbersome Medicaid applications and narrowing them down to 4 pages. Let's only focus on the questions that we really need to have answered to determine eligibility for coverage. The use of online applications is another thing that a lot of states have done for specific populations of their Medicaid and CHIP programs. We're looking for online applications and electronic signatures across the board today, trying to catch up with technology a little bit too. The other thing we did was move to a 12-month eligibility period. We've learned a lot about churning. As people talk about it, it's the cycling on and off of health coverage. When you have situations where a family has to renew coverage more frequently, and that can really cause disruptions in care and unmet healthcare needs that can often lead to more complex conditions. So we've moved to a 12-month eligibility period. Certainly if a family experiences a change in their circumstances, they're generally supposed to report that to the state so that they could do a renewal if it looks like the person is no longer eligible. but really just moving to a more continuous system of coverage and enrollment, and not unlike what we all experience with our health coverage, the open enrollment once a year to change plans and those types of strategies. And then we certainly have learned a lot from, again, the children's coverage efforts about what works for outreach and enrollment. And what we've learned there, I think, fundamentally, is that it's really important that it be done at the local and community level, because people need to understand what it means for them and their community. They need to understand the state-specific rules. And so our outreach efforts here in the federal government will be very state-focused. So, in terms of what's coming up next from CMS, as always, we're working on regulations. So we've got some new regs coming out, hopefully like next week, we'll see. I like to say imminent when I don't know for sure the date. We are now moving into a process where the states are updating their state plans for Medicaid and CHIP. Excuse me. They're updating their state plans, which sort of just brings up to the current day what the rules are for their programs. And so we are, this summer, going to be reviewing and approving hundreds of state plan amendments from states, so we're excited and terrified about that aspect. We are also, many states, and folks know the term waiver in the world of Medicaid, and many states, about half of them actually, have Medicaid 1115 waivers that they have in place. And the vast majority of those are coming up for renewal at the end of this year. I'm not sure how we got ourselves into that situation, but so we are now talking with states about what they need to do to transition their waivers as needed. If they're expanding, they might not need to have the waiver anymore. Or if they aren't expanding, what they should do to keep their coverage going and to certainly avoid coverage losses. So we're having very active conversations with states about their waivers. The other thing worth mentioning is the new option that's included in the Affordable Care Act called the Basic Health Program, which is intended to be kind of another affordable option for individuals who are at sort of that slightly higher income level than Medicaid. So they're actually eligible for exchange coverage, but they might have trouble meeting the premium obligations for the exchange. And so the Basic Health Program is something that several states are considering as an option for kind of filling that gap in coverage for the population, still below 200% of the federal poverty level. So one of the ways we're going about these communications and conversations with states is through something we have termed the State Operations and Technical Assistance Initiative. And that's something that we do. It's a multidisciplinary team across CMS, actually. So we have folks from the exchange office as well, the Center for Consumer Information and Insurance Oversight, which is running the exchanges, our data and systems group, and all of our policy teams here in Medicaid. And we meet once a month with every state, and more often if they ask for it, actually. And we talk through different policy and systems issues that they're grappling with. We answer a lot of questions. We sort of negotiate issues and really try to keep the process moving. And those have proven to be a really great partnership for making sure that we're having open communication with states as we work through this process. So the calls mostly have focused on the systems development that I mentioned in terms of that 90-10 funding. Eligibility policy, because they needed to sort of get these eligibility decisions made and get their systems programmed with the new rules. But now as we're moving through into the summer, we'll be talking a lot more about benefit design. That's going to be a big area of discussion. The law does envision the set of essential health benefits that need to be covered in the new world. And those states that are choosing to expand coverage to that low-income adult population need to design a special benefit package for them. Managed care contracting is another big issue, right? We're trying to make sure that the provider network is sufficient to take on the new populations that are going to suddenly have coverage. And also to make sure that the broader healthcare system is ready to accept folks who may have insurance that didn't have it before. So we talk a lot about day one and day two. Day one, of course, is October 1st and January 1st. We have 2 day ones, actually. And then day two for us is what do we do when the doors open and something happens and the program isn't working right, or the application has a glitch in it, or the system goes down? How do we respond? How do we support states in resolving issues and moving forward? So we're trying to do some planning around that as well right now and working in partnership with states. So this is a picture of the application. There's been lots of press around the application, and I think it's probably going to take a little longer to fill out than we originally thought. It's not a 5-minute sitting, but ultimately, again, the outcome of it is that the individual will likely get some coverage option offered to them. And so we've really tried to make it modern, make it, again, limited to just the information we really need to have to make a determination of eligibility. And again, just to really screen people for the right coverage program. So in terms of communications and outreach, this initiative is actually being housed in our Office of Communications for the broader agency of CMS, and we are right now just getting very close to launching a kind of refurbished healthcare.gov website. So that will be the home of the exchange, the federal exchange, and the place to get information. We've been working very closely with them to make sure that they have state-specific information and phone numbers for people to call to get more information about Medicaid in their state. There'll be a toll-free number and a call center for consumers where they can get questions answered and also apply for coverage over the phone. The call center actually is going to open this month or very soon next month to just, again, start answering questions for people and give them some ideas about what their coverage options are going to be in October. We're also developing training materials. We want to make sure that, again, states have what's needed in terms of how to talk about the new coverage options, how to talk about the new MAGI rules for their eligibility staff, and also, of course, the community-based organizations that will be so critical in ensuring that people really do get enrolled in coverage. Again, we know that from our experience with children's coverage efforts. And I've mentioned this already, but again, we're also going to be trying to make sure that we provide state tailorable materials that states can use to either put their logo on it or tailor it in some way to make it useful to them and reduce costs and make things go a little more smoothly. So just to close, this is one of the individuals who we think will be a great candidate for being receiving coverage in 2014. And I think this really, the quotes from him, he was part of a focus group that we conducted as we were developing the application. And Salvador noted, really, I think the theme here is the peace of mind that he feels that he'll have through having health insurance coverage. That, he used to worry about playing soccer in the park with his daughter, that he might fall and get hurt, break something, and that he wouldn't have health coverage. He wouldn't be able to go to the doctor and get his care paid for in an organized way. He might have to go to the emergency room. And so he really talked about the importance of this to him and being a parent and just how valuable that would be. So I think just really knowing that whatever happens to him is going to be taken care of was really valuable to him. So I'll close with that, and I'm certainly happy to take your questions, and thanks for having me today.